recording. Okay, I'm recording. So just to review in your hematology, um, in your lab book, there's a note here, page 29, table 2/1, that will go over the basic sites. Underneath here in the gray box are, canine, cephalic, jugular, lateral, saphenous are preferred. What you'll find in practice, and I just make this disclaimer, is sometimes if a dog is just coming in for a heartworm test, um, or like maybe just a PCB, maybe just a glucose, cephalic is generally preferred. The only problem is if the dog's coming in to have surgery and you're going to put a catheter, if you hit the cephalic with a needle and it blows, then you potentially lose it for a catheter. And just coming from specialty, when you're in ER and when I worked in anesthesia, we just didn't touch the cephalics because we knew they were primarily for catheters. So jugular was preferred. And you're going to get more blood from a jugular stick. It's going to come a little bit faster, and it has less of a tendency to clot. So this is like, you might find that your doctor where you work has a preference, but I'm just telling you kind of the rationale on, and like the lateral saphenous, I like to use that in a dog if I'm giving like a sedation. It's not a great one for a blood draw because the blood tends to come, unless I was just going to get like a glucose or a PCB, because you just don't get a large volume tendency. And let me make another disclaimer. Being in surgery is you cannot always get blood from an IV catheter. And sometimes people want to pull back on their IV to confirm that it's in, but a lot of times the catheter is in the vein, but when you pull back, it can collapse the vessel. And I've seen plenty of catheters in my days that are in, and then people go to draw blood and they cannot get it. And that, like I said, it doesn't mean that it's not in. A lot of times it doesn't work. The other thing is if you're pulling a sample from a catheter, and if any drugs or fluids have gone through that catheter, potentially it can dilute out or affect your sample. So if you're pulling from a catheter, especially one that's been hooked up to fluids or a CRI, a lot of times we have to pull back and kind of waste that sample and then pull new. So, you just have to think about that. In cats, the cephalic is going to be preferred for a large volume. Their cephalic can yield a sample, but the cephalic and the medial saphenous don't tend to bleed as much, and you don't get as good of a sample. And then in a horse, it's pretty much the jugular. You're not going to use legs for blood. That's just, it's mostly because it's dangerous. And their jugular is like a pipe. So, jugular is preferred. And then in the cow, the jugular or the caudal, the coccygeal vein. So they have if you lift up their tail, and I don't know if you guys did this when you were out at the cow farm, but if you lift up their tail in the medial aspect or right down midline of the tail, closer to the rectum, there is a coccygeal vein, and you can use that, but their jugular is preferred. The mammary or the milk vein is large, but you have to get underneath them. That would be like a last resort. You could technically use that. And then in birds, the wing vein is preferred. Some people will get a very small amount from a toenail clip, which is not ideal. But if you had to do like a quick glucose or maybe even fill like a small crit tube. Okay, good to know, Brittany, that you guys had to use that vein. So, oops, I didn't want to flip this side. And then rodents, tail, potentially jugular, rabbit. I know, a lot of rabbits, and obviously I'm sure you learned from Nima, and she's got more specifics because of her experience. An ear vein can yield, a lot of times in exotics, they've got like mini crit tubes and they have smaller blood tubes. So you don't need, those big tubes that you see that we have in the lab for dogs and cats. A lot of times if you're in exotics, you're going to use the mini tube versions of the tubes that we would use in a dog or a cat. So you don't have to draw as much. This is very good to know for the test in general, just for your experience. But serum is basically to remember that is the liquid that comes from the blood after it's been clotted. And so basically it has the fibrinogen component is taken up with the clot. So when you yield serum, it's basically plasma with the fibrinogen removed. Now you can't call it plasma after it's been clotted. It is serum. And then plasma is the fluid that comes after, you know, if a sample, I don't know if you guys have noticed, and sometimes you guys draw blood and then you go into surgery. If you come back and see your purple tube, the cells will settle and the fluid you see at the top is plasma because it is an unclotted tube. And so that's the difference between serum and plasma. Now, if you're going to, you know, we generally go by what test are we doing, what tube. So your purple top tube is your EDTA tube. And, you know, so they come with the CBC machine, or you can get them sent from the lab. But you're going to use that for your CBC, your platelets. If you need to do cytology on something, like I'm going to give you guys a tip. If you guys have a dog that has like a septic abdomen, or if we do a CSF tap from a dog, if a doctor wants a cell count on that fluid, generally we will take some of that fluid and put it in a purple tube because that will allow us to view the cells. So generally, if we're wanting to do cytology of fluid, we'll take some of that sample and we'll put it in a purple top. Your red top tube is going to basically yield serum and allow it to clot. So it does not have an additive. Now, the difference, and a lot of people get these confused, are what's the difference between a red top and a marble top. If you look at the marbling, that usually has what's called a serum separator, a clot activator, and a gel separator. So it does have an additive that will help with clotting, but it also does separate the serum from the clot. Now, if you don't have a marble top, you can get a clotted sample from just a plain red top tube. But the problem is, and hopefully you remember this, when the serum sits on the clot, the glucose from the serum can be consumed. So say, for example, you draw blood, and this happens a lot in practice. I worked in a general practice before specialty, and you know, sometimes we'll draw blood and those tubes will sit, and then it would be close to my lunchtime, and then I'd go to like spin the tubes, but we get this sample back and it looks like the cat is hypoglycemic. It looks like the glucose is really low. And it's kind of like, well, the cat didn't come in for any like diabetic symptoms, or, you know, it didn't seem like, or, you know, any issues related to blood sugar. We weren't, you know, expecting that. But what happened was the tube had sat, and, you know, there is going to be cellular components that are going to consume the glucose from the serum. So especially if you're evaluating glucose, a lot of times what we'll do, you can, now a serum separator, you will use it, and that will keep the serum separated from the clot. So that has a better chance of not affecting glucose. But even in practice, some of the doctors, the specialty doctors, wanted us to spin the sample as soon as it clotted, and then we will suck out the serum and we would put it in like there's a tube that has a white top, which is basically a clear tube. It doesn't have additives, it doesn't have anything. And we would put the serum in that and send it to the lab. So, you know, there's different ways to do it, but I want you to know what tube yields what. Now, specialty tubes we get into, we don't use a lot. There are green top tubes, and this is basically heparinized tubes. And again, it's another tube that doesn't allow clot. It's just a different additive. Instead of EDTA, it is using heparin. But this tends to be used more. So a green top tube is going to yield plasma because it doesn't allow clotting. But a lot of now, it says exotics like birds and reptiles because you get these little green tubes where you can just put a little bit of blood in. We got a new machine at BCA when I was there, and we ordered the little green tubes, and we use them for our chemistries in dogs and cats. The machine we had, I think it was called the Abaxis. It may be what you guys have in the mini lab, but the Abaxis machine ran on whole blood. So we could literally draw a half a mil from a dog and do a full chemistry panel off of a few drops of whole blood. But you had to put it in a heparin tube. You didn't want to run it off of EDTA. It had to be ran off of heparin. So again, that's a different one. And then your blue top tubes, which aren't as common, contain sodium citrate, which is, again, it's an anticoagulant, and it's going to yield plasma if you spun it. But the main reason we use a blue top is for coagulation studies, especially if we run what's called a PT and a PTT, which those are your primary clotting factors that we look at. Okay, so be able to tell me. Now, the other thing too, in practice, most clinics will use, if you guys have heard of Antec. Antec is the primary lab that, obviously BCA had bought Antec, and so that's the lab we use. Some people use IDEX labs. Those are probably the two most common labs. But usually in your clinic, there will be a book. And the book, if it says chemistry panel, it'll say we need this tube. But a lot of times, sometimes a doctor will, order a test on, and it's not a test that, we do very much. If your question what kind, and do this before you draw your blood, make sure you know what tubes you want, because sometimes you're sending the animal home and you don't want to have to call the owner and be like, oh, we got the wrong tube, you got to bring Fifi back, especially if Fifi doesn't like riding in cars, so I always kind of know ahead of time, I need a purple, I need a green, I need a blue. And your labs will also have websites. You can look this up. So you can look up what kind of test requires what kind of sample. So if you have any questions about that, let me know. Some terms to remember, basically, when we talk about, anytime you see poiesis, it's production of. So anything that's poiesis or hematopoietic tissue, like hematopoietic tissue, creates red blood cells, and hematopoiesis is the production of. So hematopoiesis is the production of all cells. Hemato is pertaining to blood. Now, you have three main cell lines when we look at blood. We're going to look at erythropoiesis, which is your red blood cells, leuco, pertaining to white, is your white blood cells, and thrombopoiesis is production of the platelets, or So those are the three components of blood, and all of those, the production has cell lines. And it goes from the bone marrow to the point that they are released. And if you remember, especially, I'm going to back up a minute. When I talked about erythropoiesis, I remember I talked about erythropoietin. It's the hormone that is released from the kidney that triggers the bone marrow to produce red blood cells. So erythropoietin initiates erythropoiesis. Hence why sometimes in renal failure, you do have anemic animals that are in renal failure because they're not able to produce erythropoietin, which then affects erythropoiesis. So again, you can have a cat that has beautiful, gorgeous bone marrow, but if they're lacking erythropoietin is supposed to trigger the production of those cells. Because when an animal does not have enough red blood cells, when you get into anemia, remember, did we lose red blood cells? Like, are we bleeding from somewhere? Are they not being produced because there is defective bone marrow? Or is it an issue with erythropoietin, and it doesn't have to do with, red blood cells die. And normally when a red blood cell dies, and I'm reviewing this right now because this is also important. When a red blood cell dies, like normal, oxygen levels are going to drop in the body. Not clinically, an animal might not be like gasping for air, But slight hypoxemia, if you remember from anatomy, is the trigger for the kidney to release erythropoietin, stimulates red blood cells. Red blood cells are released, oxygen levels come up, there is no more stimulus, and the erythropoietin does not get released, and we go back to normal. So if you remember that whole hormone feedback system, that's,
How quick about does that process happen as far as when it senses the hypoxemia, like the blood cells actually being released into the system? Because it seems like it would take a little bit long.
well, it's not, if you remember hormone reactions, let me put it this way. When you're dealing with the hormones, it's going to take a little bit for that to be detected. Like the effects, it takes a little bit longer to react to it, but the effects last longer. I don't have an absolute, like I can't say it's this level of hypoxemia that triggers it. Because if you remember, hormones help maintain homeostasis, but and then the nervous system does. Now the nervous system reacts quickly, but the effects don't last as long. Hormones take a little bit longer, but then those effects last a little bit longer. So I don't have, it should be enough to balance where the animal does not become clinical for the
Yeah,
hypoxemia.
because I understand that how that works and how long it lasts and how that stuff lasts longer, but it just seems like hypoxia is such a immediate issue. You know what I
Well,
mean?
and I think when you think of hypoxemia, you're probably thinking of the animal being it's detecting minute levels. So it's as long, the body's trying to catch it before it becomes a clinical problem.
Okay,
So,
I see. Yeah.
yeah. So the body's good about internally homeostasis, about just, they're probably detecting very small changes in levels, not to the point where my animal would feel it.
So this isn't like they're suffocating hypoxemia. This is like the air around them's a little bit lower than normal or something.
Exactly. The body is just monitoring the body is monitoring the chemical components of the blood. And so when it detects that oxygen level probably beginning to drop because some red cells have died, it's going to react to it before my animal would show. Now, like let me go to my anemic cats, because, we saw a lot of renal failure cats when I was up in Anderson, and when this cat came in, she was very tired, she was a little pale. Now that cat, though, being in renal failure, the red cells are continuing to die and not being replaced. So it did get to a point where that cat was clinical and was anemic. But in a normal patient, those red cells dying would be detected before I could clinically detect it, if that makes sense.
Yeah, I gotcha.
Okay, so each of these cell lines have a production, and then the test that we're going to run is a CBC, or a complete blood count. And this is like a very common test. It's run pretty routinely. It's going to give you, and the thing to understand about these blood tests is, what does it tell me? And why is it important? So obviously it's going to tell me my total red cell count and my total white count. Now remember, there's 5 different types of white blood cells. You're going to get an overall white cell count. And then if you remember, there's percentages of what percent of those are. And the other thing is, a CBC will tell you what percent are neutrophils, lymphocytes, monocytes, basophils, eosinophils. HB is your hemoglobin. So hemoglobin, sometimes it's written as HB or HGB. So you're going to get a hemoglobin. You're going to get your red cell indices. And if you remember, that's going to go into, the makeup of the cell, like the size, primarily. I'll get into that. Now, every CBC additionally is going to look at the blood, you guys can look at a blood film. Okay, you're not going to make a blood film and put it in the machine. But what the machine is doing is shining the light through to try and estimate the cells that are there. And, that light bounces back and it interprets that. So you can get, the blood film, when we look at a blood film to back up a CBC, we can do a differential, if you remember how we do it ourselves. You can look, the main thing that you want to look at on a CBC is morphology. Do the red blood cells look normal? Do the white blood cells look normal? Normal size, normal shape, normal color, normal amounts, and obviously looking at your platelets, which usually is done via an estimate, so you can look at a platelet estimate, possibly a retic, we'll get into that. Again, EDTA, your purple tube is what's preferred for a CBC. You can use heparin for birds and reptiles, but again, if you're doing, that's another thing that, your doctor can reinforce, or you can find out from your lab, if you have a bird or a reptile. But let's look at the individual tests that are part of that CBC. So your first PCV, now, when you do a PCV, this is showing you doing a PCV, your CBC will give you a hematocrit when you run a CBC. We started having trouble with our CBC machine at VCA to the point, the last shifts I worked at the ER, the doctor wanted a manual PCV for every CBC ran. So I would run the CBC and I would take some of the blood and run a PCV so that I could compare it, because they were having issues. So the best way, if on your CBC, your PCV looks like the number doesn't seem right, you can always go ahead and run a PCV tube and to compare. And I usually wrote it on the bottom of my CBC, like manual PCV was blah, blah, blah. Because they definitely found errors. There's plenty of patients where the PCV said one thing on the CBC, and then I ran a manual and I got a different value. So hematocrit, so the PCV is the cell volume, hematocrit is calculated. So technically it's a hematocrit when you get it on the test. But when you spin it, what we're looking at is what percentage of red cells compared to circulating volume. So you're going to look at when you spin it, and here's a good picture. Your plasma goes to the top. Your buffy coat is your white blood cells, and then you've got your red cells and your wax plug. And if you remember, you measure from the top of the wax plug, which is the bottom of the red blood cells, to the top of the plasma. Now, if this yellow to red total represents 100%, we are going to compare the plasma percent to the cell percent. So, for example, on the bottom here in the gray, canine hematocrit can be anywhere from 37 to 55. I think a lot of times we go 35 to 50. Feline can be 30 to 45%. So, that's kind of normal. Now, if you remember, what does dehydration do to my hematocrit? If I have an animal that's dehydrated, it's going to increase it. The less body fluid you have, you're going to have less plasma and you're going to have more cells. The worst I saw, I had a PCV of 88%. 88%. I ran it 3 times because I was like, no way, got my glasses, went and got 2 other people to look at it because I was like, what am I doing? Have I had like a massive brain fart and I'm doing this wrong? But the dog came in with what's called HGE, hemorrhagic gastroenteritis. The dog was basically pooping out a lot of blood. It was diarrhea. I hate to say it looked like strawberry jelly, but hopefully you're not going to have strawberry jelly donut. So the dog was massively dehydrated. And so that's why the PCV looked so high. A lot of times those animals come in with called hemoconcentrated. Because they're lacking fluids, the blood is more concentrated, more cells. We bolused that dog. This was a Cocker Spaniel, and I want to say it was like 40, 45 pounds. We bolused that dog 3 liters of fluids. 3 liters. I even looked at my doctor. I said, do you want me to give 3 liters? He's like, 3 liters. I said, 3 liters? He's like, 3 liters. He's like, Christine, just do it. Afterwards, we rechecked a PCV, and I want to say we got like 42%. So after rehydration, that PCV came down. So anytime you have an animal, and this is just a tip, if an animal is clinically dehydrated, like you see evidence of skin turgor, sunken eyes, tacky mucous membranes, a history of vomiting and diarrhea, and you look at that PCV, you want to look where it lies, especially if you have a renal failure cat that has a PCV of 30% on presentation. A lot of those cats are dehydrated. You rehydrate that, you check it the next day, and it's going to fall. Okay, so I just realized, and then the other thing to look at when you evaluate, not on a CBC, but if you do a PCV tube, a crit tube, is look at the color of the plasma. I always say that it can be an indicator if it's icteric, is it lipemic, is it hemolyzed? So that's a good indicator. And plus, you're going to crack this off and you're going to get a total protein. So, you know, you're going to look at the protein level compared to the PCV, and that can also be an indicator of hydration and anemia, and, you know, the doctor will look at that. Now, most of the time, your total numbers, you know, your automated, you know, your machine is going to automatically count the level of red blood cells. But when we look at this, we use this number to determine the indices. It has a question mark here to determine your indices, and that's going to give you more of your numbers, especially if you're looking at anemia. I'm going to get to that. So it's millions per microliter. So that's what this is representing down here. But let me talk about the other individual values you get on a CBC. Hemoglobin, which you know what its job is, to carry oxygen. That's the job of hemoglobin, and it's on the red blood cell. So hemoglobin is a component of a red blood cell. It does have a role in acid-base balance, and when you look, it kind of helps eliminate CO2, because if you remember, a red blood cell carries oxygen to the tissues, and then CO2 has to get back, so it's carried the opposite direction, and it goes and it's exhaled in the lungs. So it's going to affect oxygenation. When you guys are doing an SpO2 in surgery, when you put that little probe on the tongue, you are estimating the amount of hemoglobin that's saturated with oxygen. That's an estimation. So, you know, 95 to 100% is normal, but that's an SpO2. When you look at the hemoglobin, a hemoglobin value can be like a third, estimated about a third of your hematocrit. So if you had a PCV of 42%, a third of that would be 14%, you know, roughly a third. So, but again, a lot of times hemoglobin is going to be looked at. A lot of these indices and these other values on your CBC become important, especially when we're dealing with anemia. So in an everyday patient, maybe those aren't looked at super close. A lot of people kind of glaze over a CBC, but especially if we're evaluating any level of anemia, those become more important. Now, when we look at some of these indices, you're going to look at, you know, the machine takes into account the total red cell count, the hemoglobin concentration, and the PCV. And then it's going to estimate these values. But these tests are really used when we evaluate anemic patients. So MCV is your mean corpuscular volume. And this test, really, it's telling you what are the volume, how big are the red blood cells in the blood. So it's an estimator of their size. If we're looking at an everyday patient, you expect a normal MCV, you probably don't look at it. If you have it, this is important, if you have an anemic patient and we're worried about them not having enough red blood cells, you technically, a good sign is if you have an elevated MCV. Because if it's elevated, it's going to tell you, are the red blood cells that are there bigger or smaller? Now, I've said this before. Well, hopefully okay, let me go back. When I've talked about anemia in anatomy, or when I've talked about what happens is when an animal is anemic, they need red blood cells from the bone marrow. Now, depending on the level of anemia that's present. Now, I've not even said why they're anemic. They're just anemic. Okay. The body needs red blood cells from the bone marrow. But remember, the red blood cells in the bone marrow are going through a maturation sequence. And if you remember, when a cell is immature, it's big. As it starts to mature, it starts to shrink and become smaller. Now, in a severe anemia, sometimes the body will spit out immature red blood cells because the body's like, hey, I'll take whatever you got. If you remember when I talk about this analogy in anatomy, I said, say for example, we were getting invaded on the East Coast and our first line of defense, our Army, our Navy, our Marines, they just get taken over. Well, you've got all these barracks all over the United States, but they're all in basic training. You know, they're not ready for the front lines. But if we were getting invaded, you know, they might say, just send everybody. And, you know, all these people in the barracks are like, I'm not a full Army dude, or I'm not a full Marine. But we're like, hey, you all we got, go. I'm not ready, but just go. So sometimes within the bone marrow, you have cells that are maturing. And sometimes the body will access those cells because it's like, hey, look, we don't have enough red blood cells. And the bone marrow is like, hey, they're not done cooking. And the body's like, I don't care, just send them. So a good indicator on a CBC, if you have an animal with anemia, if you have this elevated MCV, it's showing that the bone marrow is putting out big red blood cells. So they're just bigger than normal because they're not mature yet. So hopefully that makes sense. That's a good indicator. Now, if you had an animal that was anemic and they had a low MCV, remember when cells are in circulation longer and they shrink and they're smaller, then that's telling you the cell is older. So an animal with anemia that had a low MCV, that would not be a positive indicator. It's telling you that those cells are small. Now, you are going to back this up because you guys are going to be good techs and you're going to do blood films and you're going to do these. And you can see anisocytosis. So if you see, well, macrocytosis means what? What is macrocytosis?
That abnormally large cells.
Abnormally large cells, which is a positive thing. If we have micro, it's the flip side. Microcytosis is abnormally small. As the cell gets older, it's going to shrink. So if you have an anemia with a primarily microcytosis, that's what we would call a non-regenerative, or that's a sign of non-regenerative anemia. If you have macrocytosis and an elevated MCV, then you're looking at probably a regenerative anemia because there's large cells present, MCV is big. That's an indicator of immature cells, which means the bone marrow is trying. Now, that's probably one of the number one things that's kind of looked at. You have MCH, which will give you the weight. And again, it's not as accurate, but again, if you have a larger cell, it's going to weigh more. So that can be an estimator, but I would say probably your MCV is your big one that you're going to look at. Then you have your MCHC, which is the concentration of hemoglobin, and it's, you know, this is on the CBC, but this is in grams of deciliters. And this would be when we look at chromasia. If I'm talking about chromasia, what am I looking at in the cell? What does chromasia tell me? Pigmentation, exactly. So if you have hypochromasia, it's losing color. If we have hyperchromasia, which can be an indicator of immaturity, then we've got the deeper color. So, you know, when I look at when you look at a blood film, basically all of your red blood cells should be like the same size and the same color. They have a lack of central pallor. They're going to have, you know, well, let me get to the next slide, but RDB is the width. And again, your RDB red, it's like a distribution width. it's going to be an estimator again of size. But I'd say of all these tests sitting here, the MCV and the MCHC are probably the two that are looked at the most. And your RDW indicates, anisocytosis, and that's what you're going to look at. Let me get to the next slide. This will make more sense. Here's at this top row is the maturation series. And again, if you remember for a red blood cell, let's just look at the top line. Remember, anything that's a blast is going to blast apart and make more cells. Usually your blasts are in your marrow. You don't typically find blasts out in circulation. So this is within the bone marrow. You see how big? And then you see it starts to shrink. And it's shrinking, and you can see the size is changing. The color is going to change. So that's why we're looking at chromasia and cytosis, because we're looking at the size of the cells and the color of the cells. Because again, in circulation, I'm going to come back to these cells in a minute, but let me focus on red cells. This is a good slide because it has, don't look at the purple ones for a minute, but look at these different red blood cells. When I look at a blood film, red blood cells should all look about the same color and about the same size. That's in a normal patient. Within this slide, like that one's bigger than that one. That one has, like this one's a little bit darker than this one. It's picked up a little more purple. This one's bigger. Okay, so right within this film right here, I'm like, we have anisocytosis. We have some polychromasia. Both are indicators that we don't have cells of the same size. And then you get into a prorubrocyte. Now, if I looked at a film, I would probably say that was a lymphocyte, to be honest. I would look at it and go, is that a lymphocyte? So some of these are hard to differentiate. It takes practice. That's why you bring your books with you when you go into practice. Now, a metarubrocyte here and a rubrocyte, if you go back, you got a metarubrocyte, and a reticulocyte is another name for a rubrocyte. Reticulocyte and rubrocyte, most of the time we call them reticulocytes. But do you see what's happening to the nucleus? As it matures, the nucleus is going to shrink, and it technically, in a red blood cell, you should not have a nucleus when it is in circulation, when it is in, it is nucleated in the bone marrow, but when they're spit out, a erythrocyte is non-nucleated, anucleated. So you've got nucleus here. So again, all of these cells, this would be highly abnormal to find these. This is like a kick in anemia. This has got to be like a massive anemia, because when you see this far back, if you saw this on a blood film and you're seeing that far back in the cell line, then that bone marrow is super active and trying to spit them out. Now, let me look at the next slide here. Here is an NRBC. Okay, now again, on this film, which just doesn't have the greatest color, we've got some crenation. These look like they're kind of spiky. We've got anisocytosis. We have polychromasia. All are indicators of anemia. But one thing I want to mention, let me go back. Okay. When you do an automated CBC, it's going to just estimate what the cells look like and give you a count. Now, on a CBC machine, there are not supposed to be NRBCs. A CBC machine a lot of times is going to call these lymphocytes. A perfect case I had, it was like, so good teaching textbook. Cat came in laterally recumbent. The cat was like as white as a sheet. And I'm not even joking. We ran a PCV. I want to see the PCV was 9. I'm not even joking, 9. And obviously the doctor, we did a CBC, and the doctor at the time, the ER doctor we had, she wanted a blood film for every CBC. Regardless, it could be beautifully normal CBC. She's like, I want a blood film for every CBC. I want it checked. Luckily, I love doing blood films. we do a blood film on this cat. Now, the CBC said this cat had massive leukocytosis, or lymphocytosis, sorry, not leukocytosis, lymphocytosis. So it said it had elevated lymphocytes. And at first the doctor's like, man, we're looking at, does this cat have anything viral? Because, you know, your lymphocytes typically fight. Every white blood cell has a job. So when one is elevated, it leads you on a path of, you know, if it's neutrophils, I'm like, where's the infection? If it's lymphocytes, I'm like, is it viral? Is it, you know, other issues? But I was like, this just doesn't make sense. This cat is massively anemic. When I started looking at the cells on the smear, they all were looking like this. And I was like, I bet. So I finally got the doctor. I said, look at this. I think the machine called them lymphocytes. And this cat does not have lymphocytosis. This cat has all the signs of regenerative anemia. There was a lot of anisocytosis, macrocytosis, nucleated red cells. Everything was saying this cat. But again, the machine just looks and says, this cell is about the size of a lymphocyte and has a nucleus. It must be a lymphocyte. It's not calling it a nucleated red blood cell. I mean, in this case, proved to me, you know, exactly why looking at a blood film is so essential to assessing, you know, especially in cases of anemia. But, you know, like I said, the CBC didn't make sense until you looked at the blood film. So hopefully that makes sense to you. You know, and a normal red blood cell, you know, has, like I said, I've just explained, it's smaller than a white blood cell. It has central pallor. So again, it's, you know, if it's a biconcave disc. So basically, if you think when you dip a slide, if something is concave, the outside of the cell is going to pick up more stain than the middle. That's why they have that central pallor. It's because of its shape on the side. Now, nucleated red blood cells, now if you're a bird and a reptile, they have nucleated red blood cells. That is normal for those species. Let me stop there because I want to get into retics and reticulocyte counts, but I don't want to like shove it in at the end because it's important. Do you have any questions based on today, what we've talked about?